Thank you for taking your valuable time and joining in the ECHO-HBV project, Module 4. This is the second last. We'll have one more module next week. And based on the questions and the responses to the questions, it looks like most of you are really knowledgeable about hepatitis B management. So does anyone have any cases to share with the group? Because that's really how ECHO-HBV works. If not, we'll start with didactics, the PowerPoint lecture, and then we'll talk about the cases later. Okay. Well, feel free to interrupt at any time if you want to share cases. Today's topic, Module 4, is to emerging hepatitis B therapies fit into the current treatment armamentarium we have. We also want to discuss individual patient cases, if you have any, at the end of the topic. So again, we're going to go back to our patient that was presented in the last few modules. So this is a 28-year-old woman who was born in the United States, but her parents emigrated from Taiwan.
Oh, I'm sorry, Ram. You're not sharing your screen just yet?
I'm not. Okay. Share. Oh.
Awesome.
It's working?
Yep, looks good.
Okay. So we were talking about this 28-year-old woman who was born in the United States, but her parents actually immigrated from Taiwan. If you remember, Taiwan is an endemic area which has more than 8% prevalence of hepatitis B. So she was emigrated here 2 years before her birth, and she was screened for hepatitis B, and lo and behold, she was positive for hepatitis B surface antigen. Clearly, surface antibody was negative, and hepatitis B core antibody was positive. And because of this, she finished additional serologic workup. IgM was negative. She has E antigen positive hepatitis B. E antibody was negative. DNA was about 454,000, and ALT is about 12. So now what? Any volunteers how you want to manage the patient?
Everyone is unmuted if you'd like to take a crack at it.
Her ALT is normal.
Conception, yes, ALT is normal.
So I would follow her.
Yeah.
But you said planning conception?
She's planning conception.
Then given her DNA level, I would consider initiating medications.
Yeah. Yeah. So one is that, and the other is, again, although the ALT is 12, I think we need to look at what her other risk factors, like what her fibrosis would be.
Right.
And based on that, we should make treatment decisions. So one of the important things, again, before we embark on the treatments is hepatitis B is completely vaccine preventable disease. There is a 2-dose regimen that's available now, and there is the conventional 3-dose regimen. And a combination of hepatitis A and hepatitis B vaccines are also available. And to keep vaccine in perspective, liver cancer is the first vaccine preventable cancer if you look at the history. Because if you prevent hepatitis B, then you can also prevent the development of HCC. One of the things we kind of want to highlight about referral to a specialist is, again, there are a lot of providers, even in my own community, who are very comfortable. Again, they don't have to be gastroenterologists or hepatologists. It's comfort level, and it looks like you all treat a fair number of hepatitis B patients. But when the patient actually develops more significant liver disease like cirrhosis or liver cancer, obviously we got to keep in mind that really transplant should be one of the ways to manage these patients, and we should consider referring them to a transplant center. No one argues that hepatitis B treatment has to be considered in someone who has immunoactive or immunoclearance disease. But in the rest of the scenarios, it's really, the guidelines are not in concert with one another. So AASLD versus APOSL versus EASL, there are slight variations in when you would consider treatment in the other scenarios. So we'll go over those. Now, the reason why we want to treat hepatitis B is, number one, improve survival and improve quality of care, right? We know it is not a curable disease, at least based on November 2019, today's date. And so the idea is, if we can prevent the progression of chronic hepatitis B and if we can prevent HCC, so that's the other goal. In the patient that we just described, we need to prevent mother-to-child transmission because that would limit further transmission of hepatitis B. We want to prevent hepatitis B reactivation. We want to prevent and treat hepatitis B-associated extrahepatic manifestations. And really the way we can achieve all of this is by long-term suppression of hepatitis B DNA. Ideally, we would also want to see normalization of ALT. This is biochemical normalization. And if that can certainly induce e-antigen seroconversion and surface antigen seroconversion, I think that'll be the biggest benefit of hepatitis B treatments. So who should be treated? So the decision must be based on not just the DNA and LFTs, but also on the degree of liver fibrosis and the risk of complications. So must treat patients will be anyone with cirrhosis or liver cancer. So again, any HBV DNA level, it doesn't have to be the threshold 20,000 or 2,000 like in the e-antigen positive or negative. But if they do have cirrhosis or liver cancer, they should undergo treatment. In e-antigen positive patients, typically the DNA more than 20,000, and if the ALT is elevated, and if the fibrosis is more than F2, you would consider treatment, and you would use 1 log less in e-antigen negative patients. We should consider treatment in patients who, upon monitoring, you're seeing that there is an advancement of liver fibrosis. Definitely in patients who have family history of HCC and those who have extrahepatic manifestations. Some of the extrahepatic manifestations of the membranoproliferative glomerulonephritis. Some of them can be panarteritis nodosa. So these are some of the hepatitis B related manifestations that we need to think about. Immunotolerant hepatitis B, typically around the age of 30. Now here the data is not very much robust, but we're seeing cases that once you have, once the individual is over 30, there are some other characteristics. If you're of Black race and if you are from, if you have e-antigen negative disease, again, they can progress towards liver fibrosis. So again, we should consider treating them. This again is according to the practice guidelines in hepatology or AASLD. In clinical practice, we may not agree with all of them. Again, that's why there is a wiggle room. But these are at least some of the guidelines we should consider following as much as possible. So again, you see it in the purple bar. So if the ALT is more than twice the upper limit of normal and DNA is more than 20,000, this is in e-antigen positive patients. Again, when we're talking about ALT thresholds, they're much lower than the lab thresholds. So this is a patient who would have immunoactive disease and we should consider treatment. So that is the extreme right hand. Now on the extreme left, you'll see that ALT is less than the upper limit of normal and DNA is still more than 40,000 units. So this is your classic immunotolerant hepatitis B. So like Dr. Smiley said, yes, this patient most of the time doesn't need treatment. Again, we do the fibrosis assessment. If the patient doesn't have fibrosis, he should be monitored with 3 to 6 months LFTs, and HBV panel checked. The other scenario is where you have DNA that is more than 2000, but the ALT is not more than twice the upper limit of normal. It is elevated, but not quite elevated. So in those situations, we look for other causes of liver disease. Again, if the fibrosis is more than stage 2, if there is significant necroinflammation, again, this is typically a patient who has undergone liver biopsy. These are the times when you would consider treatment. In e-antigen negative patients, you can see that the threshold is 1 log less. So again, on the extreme right-hand side, DNA more than 2000, ALT twice the upper limit of normal, you treat. The AASLD guidelines and the EASL guidelines actually favor any elevation in the ALT. The AASLD guidelines still say ALT more than twice the upper limit of normal. The extreme left-hand side basically says you don't have to treat, especially if the DNA is less than 2000 and the ALT is below the upper limit of normal. In all the other situations, when the DNA is more than 2000 and ALT is slightly elevated, my experience would be at least to do a FibroScan or a non-invasive method of fibrosis assessment, and depending on that, I make some decisions. Now, if the patient is drinking alcohol, if the patient has metabolic syndrome, you consider about fatty liver or other concomitant liver disease, I would tend to do a liver biopsy and then decide on the treatment. Why not treat everyone with hepatitis B? We know it's a cancer-causing virus. Well, in theory, yes, you should treat anyone with positive hepatitis B virus, but it's not practical. Limitations, as we know, does not eradicate the infection, it does not cure. Long-term treatment is needed. Most of the time it's indefinite and lifelong course. Unfavorable cost-benefit ratio. So again, there are direct and indirect costs. Indirect costs meaning if you are treating them with, for example, TDF, you have to make sure that they should get urine tested, they should get a DEXA scan or a bone densitometry, again, to assess that they're not getting side effects from the medications. And we worry about the long-term safety with the other medications. Implications for drug resistance, again, not typically in US, but in other parts of the world, if you embark on a treatment, patients may be put on second line or even sometimes third line therapies, and if you put them on those, there's definitely a implication for resistance. So how do we monitor patients? Let's say we decide that these patients are not yet there to be treated. So in e-antigen positive and e-antigen negative, we talked about the DNA threshold. But if they don't meet treatment criteria, we should follow them at least every 3 to 6 months. Now, if someone who has the DNA levels fluctuating between 2000 or higher, I would actually do a little bit more frequent intervals every 3 months to kind of assess whether they are in the real immunotolerant state or whether they are in the inactive carrier state. So typical tests that will be done are ALT, HBV DNA. I would favor doing a non-invasive assessment for fibrosis every year. And again, we should not forget that these patients should be screened for HCC. So again, at least an ultrasound every 6 months. Plus, again, I endorse alpha-fetoprotein together with the ultrasound, not by itself, but together with the ultrasound. And I can tell you, ultrasound is sensitive to pick up cancers that are close to 5 centimeters. So if you want to pick up cancers that are smaller in size, alpha-fetoprotein actually adds a little bit to the available strategy. And I have certainly picked up liver cancer just because of the trending up of alpha-fetoprotein.
So 2 questions.
Sure.
First question, how do the follow-up recommendations from EASL compare to like the AASLD?
Follow-up recommendations to screen are exactly the same.
Oh, I meant for like follow-up, like surveillance recommendations.
For surveillance is still the same. It's ultrasound, ultrasound-based screening every 6 months.
Okay. And and similar intervals for the different breakdowns?
Yeah, similar
Okay.
intervals for, yes.
And then for the alpha fetoprotein measurement, I know that, or if at least from what I recalled, I guess the AASLD didn't recommend it as strongly, it seemed, as like some of the cancer organizations.
Right.
Do you feel like the false positive rate is also increased with use of alpha fetoprotein on a regular basis, or?
So alpha fetoprotein, it's not, we don't worry about false positives that much. Anything over 400 is very specific for HCC. Okay, so again, if you see an alpha fetoprotein more than 400, and if your ultrasound doesn't pick up anything, doesn't show any focal lesions, you have to look for a cross-sectional imaging. And you have to kind of exhaust looking for HCC because it is quite specific for HCC. Anything over 200, or again, I would actually favor the pattern, which is the doubling pattern every time you screen. And that is actually very reassuring that you are going to pick up HCC. But what we're talking is somewhere that, so anything over 10 is going to be labeled as per labs as abnormal. So the question really comes between alpha fetoprotein 10 to 200. What do you do in those situations? So again, for me, I basically weigh in on the doubling time. And you know, there is another test called AFP L3. So the L3 fraction, especially when the alpha fetoprotein is less than 200, it helps you diagnose HCC accurately. The AASLD basically had this remark saying that if you just do alpha fetoprotein by itself, that is not going to be useful. You have to have some modality of imaging. Okay, and the textbook teaching really is alpha fetoprotein is positive and only 40% of HCC. So again, you have to do the imaging modality in order to pick up the rest of the 60%. Yeah. So now we're going to talk about the drugs with anti-hepatitis B activity. So you look at the nucleoside analogs, which is entecavir, nucleotide analogs, tenofovir disoproxil fumarate, and tenofovir alafenamide. So we're going to call them TDF and TAF. So the ones in the green are the ones that are first-line agents, and including an injectable version called pegylated interferon. The rest of them, which are in the black, they're basically the second and third line agents, and the ones that are marked with asterisk are the ones that also have anti-HIV properties. So again, when you see someone that actually has HIV as well, you don't want to just start them on TDF or TAF or entecavir because they need to be treated for HIV as well. So all hepatitis B patients, as per the DHHS guidelines, you have to screen them for HIV because you don't want to treat one virus and not treat the other virus. So how do we label these agents as first line versus second line versus third line? Well, first line agents typically have a very low resistance profile. So it's either 0 or 1.2%. The third line has the resistance prevalence of at least 75%. The second line is somewhere in between, around 25 to 30%. And I'll show you some data that we have already. So why do we have to think about nucleosides or nucleotides? These are the oral agents versus an injectable. Well, the pros for the oral agents are, well, it's easier to administer. These are oral, they're well tolerated. And what we know for sure is we can maintain response as long as individuals take the medication. The disadvantages will be resistance. So clearly second and third line, most common. Duration, again, once you start the oral medications, it's kind of indefinite. Long-term safety, we now worry about one medication in particular, which is the TDF, and there is some data that shows that long-term safety is not so much better. So in someone who is like our patient, planning to get pregnant and she wants to get a finite duration of treatment, well, an injectable could be an option. So this can be given for a finite duration, typically 6 months to a year. What you can see is, although you stop the treatment at 6 months or 1 year, you can expect sustained response, meaning you can still expect surface antigen conversion or E antigen seroconversion even after you stop treatment several years down the line. So you can expect that response after treatment discontinuation. There is no obvious resistance to interferon because it basically pumps up endogenous interferon, and that's how it clears the virus. Disadvantages is it's an injection. You need to give it subcutaneously once every week. Side effects, well, a lot of the patients who we treated for hepatitis C, they had several side effects due to the interferon, which include cytopenias, flu-like symptoms, fatigue. So it's not a very well tolerated medication. And again, it's contraindicated in pregnancy, in cirrhosis, and after transplant because, again, due to immune reconstitution, it can cause rejection episodes. So when you look at this table, this is in E antigen positive patients who were treated with interferon and the oral agents. I kind of highlighted these in the circles. So the oral agents are very, very robust. You can see how robust they are in decreasing the hepatitis B DNA level within 6 months to a year. Most of the agents, the first line agents, entecavir, TDF, or TAF, it's really robust. You compare that to the interferon, not so much. But the opposite is true. When you look at surface antigen loss that is induced by these treatments, the oral agents don't do that well. The oral agents, it's literally between 0 to 3%, whereas even a finite treatment for up to 6 months, you can see that the surface antigen loss can be between 3 to 7% with injectables. So why does this happen, right? And in E antigen negative patients is the same. You can see that the surface antigen loss is almost 0 with even long-term treatment up to 3 to 5 years. But the viral suppression is pretty robust with the oral agents. And it's not the same with interferon. So surface antigen loss can be expected in 4% by 6 months. And like I talked about, TDF, why is this less preferable? So in patients who are over 60 years, especially women, bone disease is quite common in the postmenopausal age group. Chronic steroid use or other medications that can worsen bone density increases that risk. Fragility fractures, osteoporotic fractures are quite common. Renal alteration. So again, we know that TDF basically causes tubulopathy, or it doesn't cause nephrotic, or it doesn't affect the nephron itself, but it affects the tubules. It doesn't affect the glomerulus. But over a period of time, we can see that the GFR can slowly trickle down, and we can see something like a Fanconi syndrome. So you can see albuminuria, you can see low phosphate, and again, some of the patients can develop CKD and end up on dialysis. So as we are treating and managing the patients with chronic hepatitis B, remember other things that we still need to address, because if you look at the natural history of hepatitis B, that they can develop cirrhosis or liver cancer. So things that will help with regression are if you counsel them for steatosis or obesity. And diabetes, for very surprising reasons, we actually see diabetes to be associated with increased risk of liver cancer. So again, we need to basically counsel them on all all three. And a lot of my patients also consume a decent amount of alcohol, they're smokers. And once you have multiple risk factors for cancer development, you should counsel them for prevention of all of those. And like someone asked, the monitoring during treatment. So this is from EASL, and also these were kind of congruent with Hepatology 2017. You can see the sources below. So we follow ALT and hepatitis B DNA, especially when you're treating with the oral agents. Renal monitoring is especially needed if you're treating them with TDF. HCC surveillance, all patients under treatment should be also screened for HCC, and every 6 months with ultrasound, plus or minus alpha-fetoprotein. When do we stop treatment? Generally, once you embark on the treatment, it's indefinite therapy. The oral agents can be discontinued in one scenario, which is when you develop surface antigen loss and you develop surface antibody conversion. This can be discontinued. We can think about it, especially in e antigen positive patients, if they don't have cirrhosis and they develop e antigen seroconversion. But one thing that has to happen with seroconversion is the DNA has to be undetectable. So most hepatologists, the minimum requirement to consolidate the treatment is 6 to 12 months. Most of us actually in real world will wait up to 2 years, because in real world, again, you can see that the titers of surface antibody can be very fluctuating. So in order to consolidate the treatment, we wait at least 2 years on treatment and then we stop. In e antigen negative patients who do not have cirrhosis, once they have virologic suppression, and again, there's a wiggle room here, you can think about discontinuing the treatment, because what is seen in some of the papers, especially the paper that came out of Belgium, is small amounts of viral flares that happen actually has resulted in e antigen seroconversion. Okay, sorry, in surface antigen seroconversion. So there is a small role that if they're long-term virologically suppressed, ALT is normal, and they're not cirrhotic, these patients can withstand the smaller amounts of flares and can develop a immunologic control. So moving on to the next slide, which is about hepatitis B resistance. So the third line agent, which is lamivudine, okay, you can see that by first year, which is represented by the yellow bar, the resistance development by first year on lamivudine is about 24%. And by second, third, fourth, and fifth, the resistance can reach up to 70%. The good thing with adefovir is typically when you start, you don't develop resistance in the first year, but by second, third, and fourth, you can see that it can trickle all the way up to 30%. Telbuvudine, this is one of the medications that we no longer use because it also causes a lot of rhabdomyolysis, typical of statins. So again, in the United States, this is no longer available, but telbuvudine is available in the rest of the world, and it's a pregnancy class B medication. So if you have someone who needs treatment during pregnancy, telbuvudine can be given in a different part of the world. But TDF and TAF, these are classic pregnancy class B medications, and you can see that over a period of almost 7 years with TDF, these are from 2017, so we have 2 more years on TDF and 2 more years with TAF. We do not see any resistance with tenofovir. Entecavir, it slowly goes up after second year or so, but it kind of remains stable at 1.2%. So how do we check for resistance, or when do we check for resistance? You can see here, this is wild type, and this is basically sensitive to all medications. And you can see some signature mutations that can happen. And this is your go-to slide if you want to look for resistance panel. But when you do a genotype testing, most of the labs will also spell it out for us that, okay, this virus is resistant to lamivudine or resistant to entecavir or resistant to telbibudine, okay? We have yet to see resistance to tenofovir. We don't have any real cases. So when we manage patients who could develop resistance, so if the lab or the test says lamivudine resistance, typically we will switch to TDF or TAF. Remember that lamivudine has some cross resistance to entecavir. So although entecavir is first line, in patients with lamivudine resistance, you don't want to switch to the same class of nucleoside, which is entecavir. You have to do nucleotide with tenofovir. Telbibudine resistance, again, since this is the same nucleoside class, you want to switch to a tenofovir, but you don't want to do entecavir. If there is entecavir resistance, again, same thing. So all the three of them are nucleosides. You want to switch to nucleotides. Adafovir is a nucleotide. So in a patient who is lamivudine naive, you can think of nucleoside. Okay, you can switch to a different class. But because TDF and TAF are really, really effective nucleotides and there is 0% resistance, they are in the same box as adafovir resistance. The only time you want to switch or add a second agent is if you have adafovir resistance, but the DNA level is not going down. And the same thing, TDF or TAF resistance, we don't actually see resistance mutations, but if the DNA is not going at a level that you want it to go, you actually can switch or add entecavir. And with multi-drug resistance, remember, we also have emtricitabine. So we can use something like Truvada or Descovy in order to give two agents instead of one agent. So back to our patient. So again, this is at a different time point. So same patient, surface antigen positive, DNA level is about 830,000, and ALT is now 44. So again, it's kind of above our comfort zone, right? So by AASLD recommendations, this patient is in the immunoactive phase and you should consider treatment. HCC surveillance, even in a non-cirrhotic patient, we should remember HCC is still possible because hepatitis B is an oncogenic virus and it integrates its cccDNA. So again, we have to screen them for HCC, and definitely cost effectiveness is already proven because you can prevent liver cancer and you can address liver cancer. In non-cirrhotic individuals, so this is AASLD guidelines. This is also similar to the other guidelines. So Asian or Black men, especially over 40 years, and women after 50 years, because again, there's a slight gender preponderance for HCC. So women get screened at a later date and men get screened earlier. And if they have first-degree relative or any carrier with over 40 years with ALT elevation and DNA level more than 2,000, we follow the recommendations for HCC screening. And we talked about an exhaustive length for how to screen for HCC. So this is again in the syllabus. This is 2017 guidelines. AASLD recommends surveillance of adults with cirrhosis. This is definitely a given, regardless of etiology. It could be hepatitis B or any other etiology. AASLD suggests surveillance using an ultrasound with or without alpha protein every 6 months. And again, suggests not performing. So especially if you have decompensated cirrhosis and you're not a transplant candidate, then the cost effectiveness kind of breaks even. But for me, I can tell you in real life, even if a patient has decompensated or child's class C cirrhosis, there is often a precipitating factor. Either it could be an infection, or the patient gets cholecystectomy or a hernia repair, and that patient can significantly decompensate. But as long as you make them compensated with medical treatment, diuretics, and the patient is doing well, you should again consider switching them back to the HCC screening every 6 months. AASLD recommends diagnostic evaluation with a multi-phase CT or MRI, especially if you are seeing an elevated alpha-fetoprotein or in decompensated patients with ascites. Because again, if you have ascites, you may not pick up HCC that well. So a little word about new and emerging therapies. So there are several new biomarkers which are being tested. So there is cccDNA. Most of the trials that we're doing to look for cccDNA will need liver biopsy because this is a hepatitis B genome that is incorporated into the host nucleus. There are some serum markers like hepatitis B core antigen. Now this is a composite biomarker still under evaluation. Hepatitis B RNA. Now this actually has shown pretty decent results in the recent years. There is a molecule called ABI-037, which actually inhibits hepatitis B RNA. And this has shown to be a strong correlate of suppressing cccDNA. So I think we're going to see more of this coming out in the near future. Other treatment options, there are several novel direct-acting antivirals and immunotherapeutic agents. Again, the whole idea is we need to get hepatitis B cure, not just a functional cure, but a virologic cure. And there are several candidates which also include some of the injectable options like peginterferon alpha. And you can see a lot of that in this slide. So here there is an entry inhibitor, that is one. Capsid dissociates, CCC inhibitors, transcription inhibitors. So there are at least 10 different ways how a hepatitis B life cycle can be inhibited. So again, a lot of these drugs are in the pipeline. And this is the plate that we have. And the ABI-0731 is the one that is showing good promise in the recent clinical trials. So we need to keep an eye on that. CRISPR technology, which is also looking at RNA gene silencer and splicing, that's also going to come up in the near future. Any questions? We're not able to hear you that well. Okay, can you?
Is this Elizabeth?
I think, yeah, I think that would be the safer thing to do. Particularly if you hit your head, the accident. I think I was wondering, that sounds like
Does anyone have any comments? Any case presentations? Any patients come to mind?
Actually, I have a patient, but I just thought about him while we were talking, but I have to collate it all so I could present it later because the data is scattered in different databases, but I could do it for next week.
Cool.
That would be great.
I really appreciate all you taking interest in Echo Hep B, and we'll try to make the last module more interactive. Thank you all.